Welcome to this Grand Rounds case narrative, focusing on the rash that spoke softly, a compelling case of skin rash in pregnancy. Our case involves a 31-year-old woman, G2P1, at 35 weeks of gestation, who presented to obstetric triage with a calm smile, noting red dots on her forearms. She reported no itching, pain, fevers, chills, or medications, and her pregnancy had been uncomplicated until this point. Upon examination, her vitals were normal, but tiny non-blanching petechiae were observed on her arms, legs, and lower abdomen, clustered like faint red freckles. There was no hepatosplenomegaly, hypertension, or edema, and her reflexes were brisk but normal. The initial thought of preeclampsia was quickly dismissed due to her perfect blood pressure. Routine labs were drawn, revealing a normal WBC count of 5,800 per cubic millimeter and hemoglobin of 13.2 grams per deciliter. However, her platelet count was critically low at 22,000 per microliter, a significant drop. Other results, including creatinine, AST, ALT, total bilirubin, LDH, and coagulation profile, were all within normal limits. This presented a dilemma: severe thrombocytopenia with otherwise normal liver function, coagulation, and no evidence of hemolysis. Differential diagnoses like HELLP syndrome, preeclampsia with thrombocytopenia, and TTP were ruled out due to normal liver enzymes, blood pressure, and absence of schistocytes or renal or neurologic signs. Gestational thrombocytopenia was too severe, as it rarely drops below 70,000 per microliter, and drug-induced or viral suppression was excluded by her history and negative viral panel. This left immune thrombocytopenic purpura, or ITP, as the most likely diagnosis. With a platelet count of 22,000 per microliter and mild mucosal bleeding, the team debated treatment options. Prednisone, while a common treatment, would take several days to act, which was unsuitable given her near-term delivery at 35 weeks and the need for a rapid response to reduce peripartum bleeding risk. Therefore, IVIG was chosen for a fast rise in platelet count, administered at 1 gram per kilogram for 2 consecutive days. Within 48 hours, her platelet count climbed to 65,000 per microliter, sufficient for a safe delivery. She subsequently delivered a healthy baby boy via spontaneous vaginal delivery, and her postpartum platelet count stabilized, with the petechiae fading. The final diagnosis was immune thrombocytopenic purpura in pregnancy. Prednisone was not used due to its slower onset, making it unsuitable for imminent delivery. Platelet transfusions are generally ineffective in isolated ITP unless there's life-threatening hemorrhage, as autoantibodies destroy transfused platelets. Rituximab is reserved for refractory or chronic ITP, not acute near-term pregnancy. Key take-home messages include that ITP in pregnancy parallels non-pregnant adults, but requires fetal and timing considerations. Prednisone is first line for stable cases with time to respond, while IVIG is indicated for rapid platelet increase, especially near delivery or with significant bleeding. Platelet transfusions are only for severe active bleeding or emergency surgery. Finally, maternal platelet antibodies can cause neonatal thrombocytopenia, so monitoring the newborn is crucial. Thank you for joining us for this Grand Rounds case narrative, highlighting the critical management of ITP in pregnancy.